Thank you, Alex and Emily, for joining me on this inaugural edition of my podcast in my Substack titled Rubaiyat Khan for Endless Health. Um, this is an experiment, so we'll try to have a fun conversation. I know both of you are really passionate about the topic that we're going to be talking about, which is the importance of more responsive and accountable health systems, and how do we really bring that about? Um, and we'll try to kind of uh, not just understand the contours of the problem, but try to also get at some of the solutions that both of you are at the frontiers of and really experimenting with. And it's been my real privilege to work closely with both of you. So before we begin, why don't you just very briefly introduce yourselves and your organizations? I'll start with Emily.
Great. Hi, I'm Emily Lawrence. I'm a director of research, evidence, and learning at VillageReach. We're a global health nonprofit that supports governments in strengthening their health systems and delivering healthcare to the most underreached populations, mostly across the continent of Africa. Pleasure to be here. And I lead our community Insights to Action work, which we'll be talking about robustly today.
Thank you.
And I'm Alex Ergo. I'm the Director of Health Systems at Population Services International, which is a US-based INGO with presence in around 40 countries around the world.
Thank you. Yeah, both of you have been really at the cutting edge of some of the work that we're talking about. So I'm really excited about this conversation today. But before we get at some of the actual work that you're doing, it would be great for us and our audience to understand what is the problem that we're trying to solve here, right? And specifically, if you could talk about what, like in your vast experience, like what really alerted you to this problem first, like give us some examples of how this actually plays out in the real world and how the lack of responsiveness and accountability actually impacts people's healthcare experiences and outcomes. So let's start with you, Alex.
Yeah, sure. Maybe to the question as to what got my interest in this matter, I think for many years I've been working closely with governments on health reforms. And each time I find it very striking how top-down decisions are made and how little the voice of people, consumers, clients, patients is being captured and listened to. I've been in so many policy-making workshops where, there was maybe one or two person that was invited that represented civil society organization, but that's it, right? And that person is supposed to elevate the experience of people. So I found that always that lacking, and I thought that maybe there's something we can do about it. And so I think at the core, we're dealing with health systems that were not built to hear people in real time. And people face delays, they get lost in referrals, or they drop off entirely, but we rarely know why until it's too late. In Uganda, for example, we spoke with pregnant women who were delaying their first antenatal care visit. And for many, it wasn't because they didn't care, but because of poor past experiences. And these experiences go totally unseen by traditional metrics. Yet there's growing recognition, I think, of this gap. The government of Uganda, just to continue with that country, for instance, rolled out, I think it was in 2023, a QR code-based feedback system across all public facilities. And I think that's huge. But they've also noted that it's not enough. The surveys are short, they're not longitudinal, response rates have been lower than expected, especially because people were kind of hesitant to give honest feedback while still sitting in the waiting room of the health facility. And I think that's where we can come in and help develop more robust systems.
Thank you, Alex. No, yes, that is such a universal problem, right? I have had some experience in the Bangladesh context, and one of the things that really struck me, and probably the craziest example that I've seen, is how despite building 18,000 community clinics, spending billions of dollars, the community clinics end up staying open only between like 10 a.m. and 2 p.m., which is the time that most people are either on the field tending to their crops or women like cooking at home, right? Um, and the times when me having had some experience in the private sector, the busiest times tend to be earlier in the morning or in the evening, which is the times that the public facility is just not there, right? So I think private sector generally does a better job of being responsive because they are dependent for their income. We'll delve into that dynamic further later on in the conversation. But yeah, why don't we come back to Emily and tell us how you've experienced the problem and what is it that we're trying to solve here?
Yeah, I think similar to Alex, really seeing that how top-down decision making is and having really an experience working. I led a 5-year community-based participatory research and human-centered design project in Mozambique and Malawi to improve immunization coverage around really hard to reach populations, both in the rural and urban areas. And through that work, really saw a lot of the similar barriers that were impeding immunization. It wasn't because these caregivers didn't want their children to be immunized. They deeply wanted their children to be immunized. They had challenges with service experience at the health facility, being treated poorly, times not being convenient, outreach services not being consistent. And what was really striking about that work is we brought government along with us, and that was quite used to top-down decision making, but brought them in as co-investigators, brought them into the co-design workshops with caregivers themselves, and saw how this changed their viewpoint of the health system and how it could be more collaborative, and how these metrics, like Alex said, that we weren't previously measuring and commonly don't, we're very performance, quote unquote, performance driven metrics, right? Coverage rate, supply chain data, which is all very important, but realized there was this whole subset of data missing. And luckily through that project, we were able to implement interventions, saw that they worked, government saw that they worked and improved coverage rates. And so that really inspired us to think about this project was great, had a fantastic influence on the community and on government decision making, but it's small, it's resource intensive. It takes a long time, which is all fine. We need research like that. But how can we get some of these insights more real time, routinely, and at scale? And so that's when VillageReach, really, we started thinking about how can we leverage some of our other expertise in data systems, data analytics, helping governments with data for decision making, and kind of blend these two to think about how we could meld it together where you still need one-off research, but you can get more routine insights at scale. And we really saw a gap, like Alex said, in like these metrics aren't being looked at in the same way these other metrics are, and they should be. They should be at the table with our traditional performance metrics. And so how can we work with government to do that? And so that's what really inspired us. I think also having COVID hit, and there was a real desire from governments of why aren't people seeking services? Why aren't people taking the vaccine? We need this data now to make decisions. And so that I think also accelerated the appetite and really highlighted the huge gap in the type of data that we have available for decision making at the health systems level, and kind of catapulted of like, oh yeah, this is a real need. This is something VillageReach can invest time and resources in trying to be one of the actors solving this problem.
Thank you so much, Emily. I think that's a great segue into the community insights to action work that you're leading. But before that, I think it's important to call out that oftentimes this blind spot that governments have around patient experiences and self-reported outcomes eventually comes back to bite the health system, right? Because when people are like, when governments set up a new service, there is an expectation that people will come automatically, right? But if it is not convenient, if it is not responsive to their needs, if they're not having a good experience, if they're not having good outcomes, then ultimately they're not going to feel comfortable coming there. They're not going to be utilizing that service. And like, for example, in Bangladesh and many other countries, we see this dynamic where you have public facilities, you have other facilities, and yet people are going to the local informal provider, whether it is a drug shop or a rural medical practitioner, and they provide a bulk of the service despite having no kind of oversight or support from the government. And I've often wondered why, and I think eventually I came to the realization that ultimately it comes down to responsiveness, right? If you are developing a responsive health service, then people will come. But if you're just setting up a service and expecting people to come, often that it doesn't play out that way. Yeah, coming back to you, Emily, tell us a little bit more about the Community Insights to Action initiative, and what does the framework look like? What does it solve for? And what experience are you having with it in different countries?
Yeah, definitely. So about 3 years ago, we decided to tackle this problem, as I kind of said, inspired by COVID and our community work and our data analytics work. Decided to tackle this problem and tackle it in a really systematic way. So we set out with the question of, how can you collect community insights at scale to inform responsive primary healthcare systems? And we talked to a lot of people in the countries where we work, primarily in DRC, Mozambique, Malawi, some of your other global actors, to kind of understand what are best practices, what's out there, how should we go about this? And through that work, we came up with what we call our Community Insights to Action framework, which really guides this work. And it guides developing systems and approaches to really drive systems level change by routinely capturing, analyzing, and integrating insights primarily from the most underreached populations. So that's one thing that we're really focused on, is how can we hear from the most vulnerable populations? Because we believe if we can design systems for them, that it can work for everyone. And how can we integrate that into primary care? So really core to this approach, which this framework can be applied to then design an approach that's fit for purpose for a government or project. It's not very prescriptive, but really what's at the core is strengthening and expanding community level feedback channels. So like Alex said, thinking about things like QR codes, or how can you gather feedback at the health facility level. A lot of our work to date has actually just been focused on how can we integrate it into existing monitoring tools that are already there. Leveraging health hotlines is a big, another component that we've been looking a lot at. And I know you and Alex have been as well. It's really also looking at moving from one-off surveys, behavioral surveys, validated. There are some great validated surveys out there to measure things like responsiveness, patient satisfaction, and think about how can we adapt those and embed them into ongoing mechanisms to collect those real-time insights. And then a huge focus of our framework is actually on how is that data used? How are you then working with different decision makers at different levels of the government or health facilities to actually use that data to inform action? And how are you closing the loop with the community? So how do you build trust? Not just collect a lot of feedback and then not do anything about it. Because we did see in our kind of pre-landscaping for this work, we heard a lot about fatigue and survey fatigue, feedback fatigue, and folks being like, I'm just tired of giving feedback and not seeing any change. And so really focused on what are mechanisms to kind of what we call close the loop. And then throughout all of that is our points to consult with representatives from underreached communities, whether that be different civil society groups, community leaders, to kind of get input on the way so that it's designed for them. So that's our work. We're applying it across about 6 programs at VillageReach in 3 different countries, Mozambique, Malawi, DRC, 5 countries actually, sorry, Tanzania and Cote d'Ivoire, in really different capacities. In some ways, we're applying it, working with Tanzania Ministry of Health to evaluate and work with them to improve on an incredible existing feedback system they have in place through one of their telehealth hotlines. To one of the examples I'd love to give is some work that we're doing in DRC, where we're working with government to provide special outreach services to really vulnerable populations that don't often get access to immunization services. So mining communities, border communities, folks that live along rivers. And so we're working with government to provide outreach services there. And we decided to integrate our community insights to action work there to be able to inform ongoing adaptation of how those outreach services are provided together with the government's expanded immunization program. So to do that, we did a lot of landscaping before we designed how we were going to do that. We worked with the other partners on the project, community and government, to consult around what kind of information can you actually act on? Like, what do you actually have agency and control to change within the scope of this work?
Mm.
And then also looking at validated surveys, understanding from the community, what do you want government to hear from you? And so based off that, designed a short survey that gets at, what are their preferred times and locations, like you were saying, Rubaiyat, and you did have insights there. What are other health priorities that are important to you? How do you want information? What kind of information do you need? How satisfied are you? How accessible are these sites? Really, like, what can be the most accessible place for you to get immunization services? And we work to embed it in an existing monitoring tool. So as opposed to creating a new siloed form of feedback, we were really encouraged, especially by government, of use our existing system because we look at that data already. So how can you embed it in that? Long story short, we were able to integrate it. The data is being used. We're capturing a large volume of data. And what's really unique about it is we're able to capture, because the monitoring system we're using through a partner captures GPS data, we're able to capture, provide specific feedback at the lowest administrative level of the government, at the health zone level, and then provide really targeted feedback back to those health zones of, hey, in your health zone, we heard people want services later. They want information from the religious leader, and this is what they want information on. And then, for another health zone, provide more targeted feedback and really get buy-in from the provincial level to enforce acting on those insights. So working closely with the supervisor, who then is the person that's directing, here's what we've heard from the services. We need you to report back next month on what you found and if this is working. So it's been a really cool experience. It's a short project, so we can't really tie it to outcomes yet, but we have just gotten buy-in from the national level in DRC to potentially look at expanding this and be able to do it more in the long term to help shape immunization services and see if it does improve outcomes, which we hope it does. So yeah, that's our community insights to action work and one example of many of how we're starting to apply it.
Thank you, Emily. Many congratulations on all
Thanks.
of the great efforts. So one question I have is about, have you gone back to the communities and asked them how they're perceiving the change that happened as a result of this program? Even if you're not measuring outcomes, what are some indicators that the system is actually more responsive now than before?
Yeah, that is part of our plan. So that's a great foreshadowing. The project ends this month, funding for this project. We're hoping to expand to another province. Because it was short-term, set up as an emergency response to several polio and measles outbreaks. It's a short-term project, so We haven't had the chance to go back to communities yet, but that's our plan for the next month, to then gather feedback on, did this work? How could we improve on this process? Kind of taking this as a pilot of implementing CETA so that community insights to action, so that we can improve. What we did do when we piloted this approach before we implemented it throughout the whole province that we're working in, we did go back to communities and gather that feedback, and also worked with them on, here's the type of, here's what we heard in your health zone, how should we solve these problems? And that was really a part of the feedback loop. And there was a huge appreciation for coming back, for working with them, and an explicit ask of, when you guys are done, can you please come back and share with us what you're learning? So that's something that we'll be continuing to integrate, and we'll be doing over the next month of this work as we wrap up this particular phase.
Looking forward to hearing some great results from those research. Alex, coming back to you. So we've worked together on your Health Systems Accelerator, and specifically the Patient Journey Mapping 2.0 project. So yeah, tell us more about your approach to the solution, and perhaps while you're at it, also maybe explain a little bit how your approach is different or complementary to what Emily just shared regarding CETA.
Yeah, sure. So I'm sure everyone is familiar with journey mapping, which is a research method that's been around for a long time. And maybe I should have mentioned when I introduced myself that PSI has its roots 50 years ago in social marketing. And so for PSI, understanding what consumers do, how they behave, where they go, has always been very core to our work. But initially, that understanding was really meant to inform our own operations. And so I think one thing that has evolved is the realization that, it's also important for that understanding to be elevated to decision makers, which comes back to the point I made earlier. And traditionally, journey mapping involves face-to-face interviews that are both very costly and time-consuming. And that explains why journey mapping is not something that's being repeated every 3 months or 6 months because of those constraints. And given that PSI, in many countries, we already had systems in place to be in touch with large numbers of individuals, for example, for social behavior change campaigns, for health information campaigns. We thought, okay, isn't there a way to maybe leverage these remote engagement mechanisms and think about journey mapping differently? And that's where the idea came for Journey Mapping 2.0. And before I elaborate, I just want to quickly acknowledge that what we've been able to do so far for Journey Mapping 2.0 was thanks to the support from Enders Foundation. Thank you, Rubaiyat. And also I want to mention that work was led by my colleague, Hilary Kinka, who's not on this call, and in close collaboration with Andrew Sekor and our research team in Uganda. But now back to Journey Mapping 2.0, what we're trying to do is leverage these existing mechanisms to follow people remotely over time as they navigate the health system. And we know that these journeys are far from linear, right? In many countries, we see that it's a constant trial and error process where they will go to, for example, a traditional healer, it doesn't help. They wait, they then try to go to the local pharmacy, and it's really trying to address the problem with varied levels of success, and coming back to the starting point, trying something else, and so forth. And so during phase 1, which we just recently completed, we decided to focus on one particular health area, namely delivery care. But the intention in the longer term is to expand that and to look at the journey for care more generally, and primary healthcare primarily. So we followed pregnant women in 2 districts of Uganda, and we tested and compared the use of different communication channels that included interactive voice response, IVR. It included WhatsApp, and included also an AI-powered avatar to track pregnant women's decisions and experiences along the journey. So we're not talking about just a data point. We're trying to really build an entire narrative to understand their experience for the entire journey. And I think this, to your second question, complements what Emily just described. It complements it quite nicely. I think, from my understanding, CETA really allows to surface community level feedback. And I think what we're trying to do with Journey Mapping 2.0 is more meant to unpack people's experiences, the challenges they face, and also to understand why they face those challenges. And I think if we, in some way, can combine the two, we will get both the signal and the story. So I think that would be a nice combination.
Thank you, Alex. In the patient journey mapping 2.0 approach, have you gone so far as to kind of surface some of those insights that you're getting from the journeys and try to influence the health system, or is it too early for that?
Yes and no. I think we have, to some extent. I mentioned, for example, the findings around ANC, why people didn't go and so forth. But I think the main focus of phase one was more methodological, really trying to get it right. How do you capture these insights? How do you make sure that they're valid, that they're truthful? How do you? So it was much more focused on the how rather than the insights that we actually gather. But definitely the next phase would shift that, and trying to see how we can make sure that these insights are actually making it to the ones who need them, and in a format that's suitable, and that they're also translated into action. So more on that in the next phase, hopefully.
Wonderful. Let's talk a little bit, dive a little bit deeper into the similarities and the differences in the two models, just for the sake of our audience. So one similarity I think that might get overlooked is the fact that both of your organizations are highly customer-centered and like patient-centered in your approaches, just by virtue of the history of the organization and how you've operated. I think that's one of the core probably drivers and motivators for why you even thought about this in the first place, while so many other nonprofits operating in the international development area do not really prioritize listening to community voices and patient voices, right? So really want to call that out and congratulate you for that and really taking a patient-centered view of this. The other thing that I was wondering about is the equity perspective that Emily was bringing up, which was around really like reaching the most marginalized. Alex, when you're approaching like using, let's say, WhatsApp or IVR, are we missing out on certain segments of the population, and how might we bring those voices into the patient journey mapping as well?
Yeah, certainly. That's a great question. There is a clear digital divide, and I think the methodology we'll end up with will likely be a combination of different channels to reach different population segments. But even that, I think, will not be sufficient. And that's where we'll need to think creatively about maybe involving community health workers as intermediaries that can help overcome that digital divide, or other ways and maybe it's also, I don't think we can totally get rid of in-person work, right? I think digital can take us a long way, but let's not be, overly, how to say, let's not believe that will solve it all, right? I think in the end we'll need to land on some sort of combination of both to make sure that we don't omit the voices of those who are the most vulnerable.
Mm-hmm. So if I may kind of paraphrase what I heard from both of you, it feels like Emily and the CETA mechanism is really trying to optimize that the core objective here, which is to listen to community voices and turn that into more responsive health systems. As of now, or already in the 4 or 5 years that we've operated, you've kind of brought it to that point, and you're trying to see how you can influence government and the health system to be more responsive. Whereas, and in some ways, the approach that you're taking might sometimes be high cost because there is more kind of hands-on, on the ground presence in order to collect those insights from communities. Whereas, Alex, where you're coming from is really to push the boundaries of cost effectiveness, right? Really looking at how do you get this to be as lean, as automated as possible. And of course, not all of it can be fully automated or technology enabled, but to the extent that we can make it 60, 70, 80% more cost effective, that can actually really significantly impact our ability to do this on a more continuing basis and over time throughout patients' care experiences. Am I getting that correctly?
Absolutely.
I can chime in. I think your point about, I think we would still like to move towards cost effectiveness, and are definitely, that's at the core, because to be able to do this routinely and at scale, that has to be a consideration. And as you said, you know, sending out data collectors just isn't feasible for any government to take on in a sustainable way. I think where we're starting now is how can we get the process right, which might mean it's a little more expensive right now. And how can we understand all the different mechanisms at play, particularly like how do we turn, you know, I'd say maybe we're a little bit more focused on the questions of like, how do you turn these insights to action? Where Alex was mentioning right now, their first step was really looking at
how to collect the insights,
how to collect the data. You know, we're maybe a little more narrowed in right now on who in the government needs to be involved. How do you get different departments involved? How do you, you know, get individuals who can provide incentives to take action at the lower levels of government invested so that they can encourage action, and trying to understand that component. And then once that's good, start layering on other technologies. Because I absolutely agree that I think in order to do this at scale and routinely, we need to leverage, you know, things like telehealth, you know, improvements in AI, which I know we're going to talk about a bit, especially on the analysis end of things. But I think right now we're in the start simple and then start layering on approach, if that helps. So
absolutely.
I think just want to call out, like, I think that cost effectiveness component is key to actually get governments to buy in on this approach. And the more, I think the other thing is the more you can integrate it into an existing system, the better luck you're probably, you know, as opposed to creating another parallel data system, data portal, a different dashboard, you know, all of that, the more you can avoid that, the more streamlined and hopefully cost effective you can be.
Right. Yeah, no, I completely agree with you. And that is exactly what I meant about like the complementarity of the two approaches, because you're kind of starting from opposite ends almost, right? But the direction and the ultimate objective is exactly the same. And perhaps, like as Alex was mentioning earlier, the ultimate like the way the frameworks evolve, and at some point it might even merge into one framework, right? That like captures all of the data collection tools, but also the processes and incentives that you're talking about, Emily, and we kind of build from there. So yeah, I think you're both kind of innovating at the frontiers of this from different angles, and I think it would be really exciting to see how these all come together over the coming months and years. So as we've talked a little bit about the differences, I think one thing that I would love to get a little bit more perspective on from both of you is what you've learned through the process, and like what has been most surprising or difficult. So for example, one thing that I remember from the patient journey mapping 2.0 work was just finding out that WhatsApp doesn't work as much as IVR does, right? And I would have like assumed exactly the opposite. And so really curious to know like what has been those biggest surprises on both of your sides, and also happy accidents perhaps, right? Like the things that you did not expect but it did work. Yeah. Alex, do you want to go first this time?
Yeah, sure. I think you mentioned already one, and I can come back to that in a second. But I think so. As I mentioned, we tried several channels to reach individuals, and we got a really high response rate, about almost 90% when using IVR, the interactive voice response. And what was interesting was that people described feeling heard, even though they were just responding to an automated call every few weeks. And I think that sense of companionship through a phone-based survey, to me, was quite striking. But it also hinted at what a responsive system might feel like in practice. And I think people didn't just want to answer questions, they also wanted to get information back. Many asked why the surveys couldn't also offer health advice, which also points to opportunities to integrate journey mapping with, for example, national hotlines, which Emily referred to earlier. And then the point that you just made, I think, about the surprise with WhatsApp, I think the disconnect between the stated preferences in terms of communication channel and the actual behavior, that was really a surprise. So in a digital preferences survey that we conducted beforehand, participants overwhelmingly said that they prefer to share information over WhatsApp. But then when we piloted it, we got only 11% of the respondents who completed even just one survey compared to the 89% on IVR. And I think there were several barriers. I think many participants reported not having data, for example. And even among those who did start the survey, we saw a sharp drop-off at the first open-ended voice question. And I think that suggests that they really struggled with self-recording responses, either because they were not familiar with it or because they were not comfortable sharing information in that way. And so, yeah, that said, I think the few WhatsApp voice recordings that we did receive were incredibly rich, much more detailed than what you can get through IVR. And so there's clearly something worth exploring here. And we're thinking about how to better prepare participants in the next phase. That's something that we want to test through, for example, better onboarding or even small upfront airtime incentives. And then how to design the WhatsApp flow in a way that builds comfort with open-ended voice responses over time. I think also we still need to get much better at combining quantitative data and personal stories. And we'll all agree that both are important, but they require also slightly different approaches, for example, in terms of sampling. And I think this is something also we want to work on in the next phase. And then I think something that was also interesting was that the trust, especially with IVR, the importance of trust. And I think that had to do with the way we recruited pregnant women. We worked through village health teams. And I think that made a big difference because people were hearing about the survey from someone they trusted and not through just a random phone call out of the blue. And so that familiarity must probably have helped build confidence and made them more willing to participate. But then moving forward, we'll need to see how can we achieve the same more cost effectively, because again, you don't necessarily need to, in the future, have to rely on village health teams. So let's see what are the alternatives to build that trust. And we have some ideas, but they need to be further explored.
Thank you, Alex. Your point about the difference between stated preference and actual revealed preference reminded me of what Steve Jobs said about customers not knowing what they want, right? Emily, coming back to you. So what have you learned through this process, and what have been the surprises?
Yeah, I think, well, what Alex said about stated preferences and kind of the preference for IVR really resonates. Some adjacent learning that we have at VillageReach. VillageReach supports a lot of telehealth work in different countries: Malawi, Mozambique, Tanzania, Lagos State in Nigeria. And some of what we've seen in that work, more reaching out for health information and lightly starting to test how we can leverage those platforms to also collect patient feedback data, and in some cases, journey data around immunization journeys. In our work in Lagos, we found that 57% of the most vulnerable population only have access to basic phones, so they might not have WhatsApp available, but IVR, something like IVR could work really well. So I think one thing that we've really learned is understanding your population, what they have access to, and then tailoring around that. So in a way, I was encouraged to see some of PSI's research around IVR because it is a bit more accessible to a wider population. Which in a way is really exciting. And we've seen some similar challenges with WhatsApp use and uptake and sustainment around the health education work. But interestingly, where we've had health hotlines, where we have a WhatsApp platform and a health hotline, we do see men accessing the health hotline more, calling in, and women accessing WhatsApp more. So I think there's still a lot to unpack in that space around preferences and use of different technologies and how that might vary across different vulnerability indexes, gender, etc. So an area that has, I think, surprised me in how much you can really dig in and how many questions there are there about what platform is best for reaching who. I think other than that, some things that we've really learned, I alluded to earlier, which I think in some ways surprised me and in some ways didn't. I think when we started out on this journey of implementing this work, we really thought we would start out with let's leverage the best tech out there. Like, how can we leverage AI to do this? And really what we've come away with is we need to start simple and then evolve. So like what I said, we need to get the systems right, nail down the process, nail down the buy-in, particularly from key government stakeholders that we're working with at the national or subnational level, and put more of our effort in that up front and then layer from there. So I think that's been one of our biggest takeaways, and that you can't tech your way out of a broken feedback loop. You have to kind of get the process and then layer it on. I think the other big learning we've had is standardized metrics and I think this is a big question I still have, is we need standardized metrics to be able to, one, advocate for use of this type of data to measure responsiveness at the country level and globally, and make it, a standard thing that's seen as important and as valid as other data that we look at in public health. However, it also needs to be tailored to local context, and it needs to be useful to the people who need to use that data. So how do you find that balance between standardized metrics and also asking communities, what do you want to give feedback on, and asking decision makers, like, what can you actually act on? What do you have agency to act on and change so that it can actually be useful? So I think that's one thing we've learned, that latter part is really what can actually drive this data getting used. And so outstanding questions are just, how do you marry those two together in a meaningful way? Yeah, I think those are some of our biggest learnings. And then, I'd say last, like, granular data really can help drive decision making. I think that's been another key takeaway for us, especially in our DRC work, in comparison to work where we've started to try to integrate feedback loops into like a national health hotline, where you get scattered data points all over the country, and not really robust sample sizes in a specific geography. You can kind of get some signals of like, okay, generally here's where the country might have some preferences, but then it's kind of hard to tailor feedback to specific populations or contexts, whereas our work in DRC, we were able to get really granular data at smaller administrative levels that could actually make these small changes to say like a preference for rural communities in DRC for late immunization times, like evening immunization times was something that we saw. They can actually probably try and implement that, and we can see that there's variation versus the urban and rural populations in that area. So really the need for kind of more granular data, either about certain populations or within a geography, we're just finding can make it a lot easier for decision makers to take action, which means getting large sample sizes, which is kind of hard. Yeah.
Of course. Partly what Alex is trying to solve as well, right? So any insights about how engaged or interested decision makers, especially within the government, were to engage with such data? And I think I remember from a prior conversation with you that you were actually pleasantly surprised with how much interest and excitement there was to listen to this data, which really surprised me.
Yeah, it surprised me too. I'd say we've seen so far the most success in Mozambique, where we're starting to layer, where we have worked on that community-based participatory research project and then have thus implemented a robust intervention, and now we're integrating routine feedback. And was really striking when we first presented the idea to district and provincial level decision makers of we want to do this more routinely and we think it's really important, that there was like a resounding yes, we need this kind of information, this is important, and we agree to it. And I had a hypothesis, well, this community, this province might be a bit unique because we've worked with them for 5 years, you know, on this deep community-based participatory research project. So they've seen the value in it. They're buying in. They're suggesting, you know, they're giving us a platform to present this data on a monthly basis. But then I think also in DRC, we just presented the work that we were doing with this in one province around the community insights to action, and had a national member from the immunization team there who was like, this is the type of data that we need. We have a ton of surveys going on, but none of it is telling us, you know, what do people want? Like, what time do they want services? Are they satisfied with those services? And really an appetite for this data and seeing. So yeah, we've seen a positive, much more of a positive reaction than I had anticipated. But I think what we've learned is you have to show them. I think the idea abstractly doesn't necessarily always appeal to a decision maker. But if you show them the data and you can have a small proof of concept of like, look, there's variation in preferences for times based off of like rural and urban. This is something we can customize to, then they can see the value in the data and might want more. I think we've gotten a lot more traction now that we've had proof of concept. And they can actually see like a dashboard with the data, gets a lot more buy-in than talking about this concept more abstractly. I think we were running into a bit more apathy, kind of like, well, yeah, that sounds important, but I don't know, like, what does that mean? That sounds really time consuming. Will that be helpful? So yeah, I think that's been our kind of with the start simple is like get a proof of concept and get that buy-in, and then you can build from there.
That is super interesting. Really calls into focus for me the importance of, so you both talked about kind of differences between different contexts. So in terms of the kind of data you need to collect, in terms of preferences for which channels, but there's also differences in terms of governance culture, right? So if like in certain countries, you might have governments that are more willing and responsive to engaging with such data. In other countries, governments might be more apathetic. So also kind of picking the right battles at the right time and generating those proof points, and also taking it to the next level where you can draw the link between responsiveness and outcomes, right? if you can be more responsive, does that actually lead to greater health outcomes? I think that's what's going to convince a greater number of stakeholders in the future what the importance of this and to standardize this approach. Alex, I want to come back to you on one of the questions that Emily posed, which is around this balance between standardization and tailoring to the context. I know that you guys are also doing some research around what are the validated metrics and benchmarks data structures out there, and what are you finding from that research, and do you think that it is possible to standardize it while retaining a high degree of flexibility?
Yeah, I think you're probably referring to a different work stream that PSI is engaged in, and that's led by my colleague, Andrew Sekor, and that's around client experience of care. And I think there is definitely need for more standardized metrics in that space. I think client experience of care historically has typically been very much focused on specific services or specific products. And I think what's lacking is a broader, more holistic understanding of client experience of care and robust metrics to capture that. And so the idea is to have these two work streams, the journey mapping and the client experience of care, merge. And so how do we then build in these more standardized metrics into the way we try to capture how people who navigate the system experience care at the different touch points. So that's the two are currently still being developed in parallel, but how do we then bring them together?
Right. Yeah, there's still a lot of open questions in this space, and I'm really excited that we have some of the best minds and doers in the world focused on this. So really, please keep up your efforts. As we kind of start to wrap up this conversation, one of the things that I wanted to touch upon is the question of whether governments truly have the incentive to listen to client voices, right? And specifically around like if you look at going back to the original problem statement that we talked about, most health systems are not very responsive, and I'm just trying to get at like why is it the case that it's not that responsive, and we might come up with the most robust and beautiful methodologies and mechanisms, and yet it might not succeed if other structural problems persist. So there are like incentive issues. I'm sure there are power dynamics at play. There are financing related constraints or kind of incentives. So just curious to know like how you would categorize the state of play and the structural limitations, and maybe shed some light on why is it that we've not seen more movement in this space beyond your organizations. Emily, do you want to go first?
Sure. And I'm very curious to hear Alex's thoughts here. I mean, I don't think I have I have some hypotheses, I would say, but you know, I think some of the financing structures that have been set up in a lot of the governments that we work with, and you know, you and I, Rubaiyat, have talked about this particularly, you know, focus on vertical programming and siloed programming of different you know, health focus areas, I think contributes to some of this. And I think what you need to have some flexibility in your financing to be able to respond and then design a system, and all the way down to the lower levels. So there has been some interesting work, I think, done around, and it's not my area of expertise, but like what happens if you give more flexible and funding and autonomy at like the health facility level? Like, can they be more responsive? I think those are really interesting questions to start to unpack, of if there is a bit more autonomy there to make decisions at those lower administrative levels of government. Can we start with kind of those areas getting to be more responsive to their specific community needs? So I think that's one reason that drives it. I also think that there's just been a big push for the way that our information systems are designed, and the type of information that decision makers get to make decisions is all really output and outcome oriented, or really performance metrics, and not looking at, which is important. We need that data, but how can you also marry it with this other kind of experience data that can really give a more holistic view of the health system? So if governments haven't been provided with that data regularly, it's hard for them to actually use it and make decisions. And I think that also goes with like community insights. They're just not regularly institutionalized. Typically, this type of data is conducted as one-off surveys, or a separate siloed survey, or it's run by the communications department in a government, or the behavioral health department, and not like primary health care. And so there's just not like a bringing together of this kind of information for a holistic view of the health system. So those are like a couple. I think there's a lot of other factors at play, but those are the two that have, I think, really stand out to me, is really like financing structures, and kind of lack of like how these data are institutionalized, even at the highest levels, even at like the global levels, like how we're kind of measuring like the health of a health system, to what extent are kind of measures of responsiveness incorporated there to really normalize that, these are key metrics we should be looking at, in addition to very important measures like the function of a health system and, the outcomes.
And that second point is what I was trying to get at, right? Because it is like you've correctly pointed out that it's not just governments, our multilateral institutions, our even something as big and all-inclusive as the WHO, often does not really put sufficient emphasis and focus on responsiveness, accountability, patient experience of care, and things like that. And I wonder, like, how deep of a blind spot that actually is. Is it just a honest mistake, or is there like something deeper underneath all of that? And we just, as health systems, oftentimes health systems, I know, at least from my Bangladesh experience, that a lot of health systems are driven and run by trained physicians, right? And physicians are, by definition, trained to look at it from outside the patient, right? And so taking the patient's point of view is very, very difficult for a physician. And that maybe plays out significantly. At least I know about the Bangladesh context, that the system-centeredness of how the system is designed often results from that lack of patient perspective being present at the table of decision making. So I wonder how much of that plays out in all of these multilateral institutions and governments across the board. But let that be an open question for our listeners to ponder about. Alex, if I had to come back to you on this question, what would be your response?
I think I would echo a lot of what's already been said. I mean, you touched on the incentives, you touched on the fact that, physicians come with a maybe slightly different perspective. I mean, all really valid points, and I think they all play a role. I would also add to that, as we mentioned earlier, health systems were never really designed with real-time accountability in mind. And I think one of the big reasons for that is that the technology wasn't there yet to make that feasible. And I think we're entering a new era where we can demonstrate that it can be done, and we can demonstrate the benefits, right? So as was mentioned already earlier. So I think it's bound to shift. It's a matter of time, in my opinion. But of course, then you have all these, these factors of power structures and incentives, sensitivities, all of that. But I think we can overcome them. And there was one more point. Yes, and I think also what's important here is to have a champion at a high enough level in the leadership of those institutions. Because we know sometimes the competition that exists between departments or the turfy attitude. So I think if it comes from a high enough level, and we've seen that we've had other examples, not related to journey mapping in countries like Nigeria, or where, if you have that support and it becomes like, almost like imposed on the system to do it, the naysayers are the ones that quickly become the exception, and they realize that they have to change their behavior to be part of the discussion. So I think that's also an important factor to keep in mind.
Thank you. One thing that just occurred to me is none of us are probably doctors, right? And in my experience, anytime I've seen a truly patient-centered model, it's often not run by doctors. And people have often asked me why I started working with pharmacies in Bangladesh, because nobody in Bangladesh works with pharmacies. And the only response I had was, I'm not a doctor, that's why. So anyway, but now that we have some understanding of the potential direction, let's kind of end with a more kind of a vision setting exercise, right? Like, what is it that health systems could look like if they were more responsive? Like, what is your vision for the future health system? Maybe in a few words or sentences.
I can start. I think we're thinking about a future system where feedback is a standard input. It's not an exception. Where data is collected routinely, where it's disaggregated meaningfully, and where it's actually being used in planning. And there would be also space for stories, not just scores. And I think another feature of that future system would be the much greater degree of interoperability, so that feedback can be connected to other types of data around quality, around cost, around access, around utilization, and so forth. And most importantly, I think, where communities would see the results, so they know that their input really matters. I mean, that's really in a nutshell.
Thank you. Very, very well put.
Yeah.
Emily?
I'd say, Alex, I mean, I share your vision completely. I think the one thing I would add to it is an outcome I would want from that vision that Alex outlined, because it aligns with my vision as well, is that health systems can be more creative. If they have those kind of inputs, they can design around the needs for their people, so that it might look different than what we're used to. And I hope there's a more creative thinking about how we can deliver care to really meet the needs of those most underreached populations, if we have those mechanisms to listen to them routinely and be able to pivot, and that we can create systems that, with that data, have enough flexibility combined with rigidity. You do need rules and standards in a healthcare system, but there's some flexibility there to be able to pivot and really shape systems in the vision for those most underreached populations. And I don't know what that will look like. And I think that's really exciting. That has the potential to be really exciting if we could enact that vision.
Yeah. If I may, I think that also leads to the example you gave, Rubaiyat, right, with your pharmacies. I mean, just having those insights and will basically highlight the role that they already play, right? But that's often neglected or, ignored. And I think that's one way, like just making sure that pharmacies are really considered part of the health system, and drugstores and private clinics and other channels that have been kind of, neglected, because it was all focused on, probably in some countries at least, on public sector delivery. So yeah, that would be interesting.
Exactly. And like, some of the most interesting models that I've seen like leverage places like schools for healthcare delivery for kids, right? Like a school is not seen as a healthcare institution, but it could be because so many kids show up there every day. And those kinds of opportunities we are currently probably missing because we don't have those insights.
Right.
So really, really wonderful point, Emily. Let's kind of wrap up with some concrete next steps and things that we could do in addition to developing the frameworks and testing them out in the countries that you're already doing it. So, of course, like we've already started talking about a community of practice around some of these ideas and bringing together the insights, maybe creating shared frameworks that all of us can use and build on together. I think there's also probably a role for multilateral institutions. Maybe there is a role for us to advocate with multilateral institutions. We've had conversations with the World Bank and the WHO, and they've seemed quite open and interested in some of these new ideas. So what would be your kind of call to action to the ecosystem and different stakeholders within it?
Happy to go first. I think maybe on the COP, the idea of a community of practice, I think there are also clearly from conversations I've had with including with multilaterals, there are definitely a lot of questions of common interest that we're all struggling with. And I think having the opportunity to look at that learning agenda together and compare notes and make sure that we take the best from all these different experiments that are going on right now, I think will be very valuable. In terms of concrete next steps, I can think of a few, and I'm sure that's not exhaustive, but one is, I think there's still quite some work to do to further refine and improve the approaches and address the many outstanding methodological questions, some of which I alluded to a while back. And so we still have some work to do to reach a point where we have robust models for continuous feedback collection that are low cost and scalable. And then the whole interoperability agenda, I think, is something that needs to be pushed alongside so that information we gather can, from different sources can be combined and turned into really useful dashboards or insights that can then be, packaged in a way that will resonate and that's also relevant to different audiences. And that's not just the policymakers, that's also the people in the health facility, the district health management teams, and so forth, so that they really can easily act on that data. And then another important, and it's not necessarily sequential, right? But another important point to already start thinking about now is how do you institutionalize these approaches? How do you build them into national systems so that they really become routinely used and no longer dependent on a PSI or a VillageReach that runs them alongside. So I think those are, and again, there may be many more, but I think those are some of the big items I think that we need to think about.
Thank you, Alex. Emily?
Yeah, I completely agree with Alex. I think just to kind of hone in that point, there aren't many, if any, good models of how this is. We have frameworks out there of how we think this should happen, but models of how it actually works and leads to better outcomes are lacking. And so I think continuing to experiment, share learnings, adapt, iterate, and solidify around a couple different models that different health systems can pick and choose from is a really concrete step forward. And that's a long game, though. That takes a long time to get to that point. So I think also in the interim, the point you made, Rubaiyat, I think, advocacy and just like the importance and elevating that, responsiveness and different ways of measuring it and how we measure it and look at it. We need to do more advocacy around that and elevating it at, not just within the governments that we're working with, but also with these, larger global institutions as well. And so how can we really push for them to be at the table with this experimentation with us as well, so that, you know, they can take that and turn that into global guidelines and create, you know, some guidance that folks can, other systems can pull from, I think is also really, really needed right now. So I would, you know, I agree with everything Alex said, and would just add that. Yeah.
What a good place to, yeah, Alex, go ahead.
No, just maybe one more point, and I think you referred to it at some point, Rubaiyat, but I think closing the loop where what we do here is not an end in itself, right? It's a means to an end. The end is better outcomes. It's better, I mean, first of all, better or more easy access to the care that people need at the right time, and then eventually better outcomes. And how can we demonstrate that link? I think will also be very critical, and that's an entire research agenda on its own.
Yeah.
Yeah. Sorry, now Alex adding one last thing. I think how can we bring, and I'm glad you brought that up, because I think it would be a shame not to bring it up at the end, but how are there different advocacy groups that represent underreached populations more globally, like maybe, you know, that can be at the table as well in helping shape how these systems work and the models, so making sure that we're also advocating for those voices. And I know there are groups that exist. I won't embarrass myself by trying to list them, but, you know, how can we bring them to the table as well, so that, you know, starting to walk the talk as we're thinking about these systems.
Thank you both. What a great place to end. I think ultimately, the reason we want responsive health systems is so that our people can trust our health systems more, right? And once they trust it more, they'll use it more, and then they'll have better outcomes. And so just closing that entire loop and really making sure that we are responsive for those end goals is really, really important. And I hope that through our collective efforts, we can actually make a dent in that ecosystem and really prove the point that there's a better way to do things. So thank you both for your dedication and wonderful work in the space. And I look forward to many more years of collaborating with both of you. Thank you so much for being with me today. And I hope you enjoyed the conversation as much as I did.
Well, thank you so much.
Thank you.
Yeah,
Yeah,
real
really
pleasure.
appreciate it. Thank you for creating the platform.